I'm probably on. There are certain situations that send me into not a rage, but just crying, frustrated, can't get myself together. And my husband is at the point, he doesn't know what to do, how to help, what to do. He says, honey, what can I do for you? You know, and if that is what it takes to understand bipolar, then the medication I'm on should control all this anxiety, or do I need to discuss more medication with a different, like Amy's gonna be my counselor pretty soon, I got a psychiatrist, you know, am I going down the right road to getting better? And will I have it for the rest of my life?
Can I interject about being the husband? She can have taken all her medications for the day, and 9 times out of 10 the medication works fine. But there is that 10th time that it doesn't take very much to set her off. I mean, it could be, oh my gosh, I've lost my cell phone.
Or oh my God, it's usually the simple things.
We've recently had a small family problem that is just, regardless whether she takes her meds or not, she's a crying mess.
Sure.
What can we do about it? So it's,
Right, well, so I think that for a lot of it, that you're not going to get 100% coverage with your medicines. I think that there needs to be some understanding that you're going to have bad days, bad moments, and part of what we do as a team is try to work behaviorally with you to try to figure out how do you deal with things in those moments.
Right.
I think Dr. Bess and I, back when we practiced together, we kind of talked about this 80-20 rule. That, you know, we hope that 80% of the time things are okay, things are stable. But you're going to have those 20% breakthrough symptoms, breakthrough days, times when things aren't so good. So I hope what can happen is we really
What do I do about this breakthrough moments?
Right. But
When I have them, what do I do? How do I handle it?
Sure. I hope that's what we can talk about is behavioral techniques. And it's different for everyone. Different things work for different people. But I hope to be able to, talk with you further about your history and figure out what's going to work for you to get us.
Let's go with one of the ones on the card. Oh, you have a comment?
Yeah, I do. And I want to give you some hope and some inspiration, okay? I was diagnosed a while ago. The biggest thing that I ever learned to do was to self-assess every morning where I am and constantly self-assess where I am and learn to be flexible and to deal with it, because every day you're going to wake up different. Every day is going to be different. It's how you react to it is what changes it. So you got to learn that flexibility and that self-assessment.
And sometimes I like to think about it like a race car, like a brain that maybe has bipolar or mania. It's like foot on the gas and the brakes maybe don't work as well.
Right.
And so the
Most of the day, I am just a cheerful, easygoing, sense of humor, you name it. I'm usually in a very good mood. But then something or someone will say something to me that either hurts my feelings or breaks my heart, and that sets me off into that bad moment. And I'm only in that bad moment until I can basically resolve it with a knee and then move on out of that bad moment.
but that might take 3 or 4 days.
Right. Sometimes it does. Sometimes it just depends. Depends on what the situation is.
So one of the questions up here is, it says, I hear the terms bipolar disorder, schizophrenia, and schizoaffective disorder. I don't know the difference, if any, between them. So I think we get this question a lot in the clinics and in the hospital. So I think one of the trees that we think about is in psychiatry, there's mood disorders, and then there's what we call thought disorders. And bipolar disorder we think of as being more of a mood disorder, whereas schizophrenia is more of a thought disorder. Now, schizoaffective disorder is kind of like a hybrid between those two. So imagine those two circles kind of overlapping where there are some thought disorder, what we call psychotic symptoms, but people also have mood fluctuations. So a way to think about that is, someone who has psychotic symptoms can have moods too, can have bipolar disorder, can have depression. It's kind of like you're going down two separate branches of a tree there, and then schizoaffective disorder is sort of like a hybrid between those two. I don't know if that's helpful for whoever asked the question.
And to add to exactly what you said, we all think about diagnosis a lot, and in part because we have to, but also it's a way to think about things. But really, it's about helping people get back on track and helping people with their symptoms or their problems. I jokingly, this isn't 100% true, but I jokingly tell my residents that the only person who's really worried about the diagnosis is the insurance company. Okay. Of course, the diagnosis is important. I mean, the diagnosis is there so we can study it, so we can have a shorthand of communication between practitioners. Okay. But you alluded to this. The experience is different for every single individual. In science, we call that the N of one. Your experiment has one subject, and that's all it's ever going to have. Okay. And so I encourage people to learn about these diagnoses, to learn about all the science. But you need one practitioner who called you schizoaffective 5 years ago, and then have it revised to bipolar when you see us at non-9C, and then 10 more years you're gonna see Amy at Packard, and she's gonna say, I wonder if you're schizoaffective. That's frustrating, but it's not really the main issue. How are you doing? How's the treatment helping you? How are you functioning? And somebody was asking about a couple of physical things. So, are bipolar people more prone to chills or constant clamminess? And I'm going to go ahead and read the second one too, because it's kind of the same answer. Do people taking lithium have problems with motor control, slow movements, heaviness in the limbs, etc.? Anything that kind of leaves the mental or the emotional and goes into the physical, it's important to make sure that the individual is getting a good evaluation by a medical doctor. We're Dr. Mortenson and I are medical doctors, but by a person who practices internal medicine, family medicine, pediatrics, something like that, who's more in tune to searching for the causes for something like chills, clamminess. I showed you a picture, a slide of things that can be associated with bipolar, and also that some of it is associated with medication. All the medications have side effects. So the simple answer to the second question, do people taking lithium have motor problems? Yes, absolutely. Tremor, slowness of movements, feeling heavy, feeling clumsy. Yes. That's why we check blood levels, that's why we monitor the response. Some of it is going to be a matter of how much of that can you tolerate versus the mood problems that could happen if you weren't taking it. And that's where that team approach and the collaboration comes in. But if somebody, I don't know that bipolar patients, and you correct me guys if I'm wrong, are more prone to chills or clamminess, I would be concerned about some medical cause, maybe a thyroid problem, something to do some basic medical tests for, or medication as well.
Yeah, so I had a question that states, are there support groups for families with bipolar loved ones? And that's a great question. I can at least speak to the University of Michigan, the Rachel Upjohn building where the Outpatient Psychiatry clinic is located. We do actually offer a support group twice a month for family members of individuals who experience bipolar disorder. And it is, I'm blanking on what day it is right now.
There's flyers.
There's flyers.
Flyers, NAMI flyers outside too.
Okay, so there are flyers on the table right outside the door, but it is a great opportunity. You can come at absolutely no cost. We do not bill for insurance. It is an open group, so if you come once and you decide it's not for you, then there's no obligation to come back, or if you can't make it twice a month and you only want to come once a month, that's an option as well. And the other really great thing about this group
was that at the same time the family support group is going on, there's actually also a support group going on for individuals with bipolar disorder. So you can actually come with your family member who has bipolar disorder, and you can both have a support group, going on at the same time, but they're actually separate groups. So that resource is absolutely available, and I don't know if there's any other support groups in the community.
NAMI.
Well, the NAMI flyer is out there, but I don't know if you know of any other either worth mentioning.
A couple maybe straightforward ones. Can SSRIs contribute to mania? Yes. It's a controversial issue whether they're even helpful in depression that goes with bipolar disorder, but there are times, sometimes this is how the bipolar disorder gets diagnosed, is someone comes into an office with depression, they get an antidepressant, which is very much the standard of care, and then they get manic, and there's a very clear relationship there. And that person has bipolar disorder, just so happened to took the antidepressant to trigger the mania. Are the people with bipolar disorder who take SSRIs and get helped by them? Yes, there are. Can someone with dissociative identity disorder have bipolar? Yes. I mean, it's one of the things that can be, we say comorbid, can happen at the same time. Some overlapping symptoms, perhaps. It takes experts to kind of tease those out, and that takes a long time sometimes.
Yeah, I have a couple that touch on the same thing. Essentially, how do we as loved ones effectively deal with mood swings or episodes? So I think the biggest thing is just educating yourself about the illness of your loved one, understanding the clinical, biological part of what's happening with them. Understanding, again, when we talk about people respond to different things, it is an individual kind of thing. So if you are with somebody, your loved one, and you can say, how can I help? What makes it better for you? Have them have a conversation with you. When I'm like this, A, B, and C are helpful. D and E are not helpful. Be able to have some communication with each other about what might be good when someone's in an episode. I think also, taking care of yourself as someone, as a family member who lives with someone with bipolar disorder. It's important to take care of yourself, get the help that you need, get the support. If you need to go to counseling, if you need to go to the support group, be able to talk to somebody else, because it can be a very intense situation.
I have a related question, which is, are there options besides medication to treat bipolar disorder? So probably everybody up here can address aspects of this, but the short answer is yes. So just remembering that bipolar disorder can be, high or low, depression or mania or what we call hypomania. There are a lot of therapies to treat depression and mania, especially depression. So things you might have heard of, like cognitive behavioral therapy or dialectical behavioral therapy, interpersonal therapy. There's a lot of great different types of therapy, social rhythm therapy. But in general, I would say the gold standard for treatment for most people is a combination of medication and therapy. But the short answer is yes, there are a lot of different therapies depending on what you're struggling with at the time. And these guys might be able to address some of the questions about therapy a little bit better than I can.
And then I tossed it over there, but there's also ECT, which is, you get some medications, but the medications are to put you to sleep for the procedure. Electroconvulsive therapy is very much mainstream practice. It's very effective for certain types of depression, certain types of mania, and sometimes it's unfortunately overlooked as an option because of stigma, availability, etc. There are other.
Could you repeat that?
Pardon?
Could you repeat that phrase? What therapy?
ECT, electroconvulsive therapy, so shock therapy.
Oh, really?
There are lots and lots of things in the media, going back to the 50s, movie portrayals and other things, and there are lots of more recent portrayals that, at least from what I've seen, are a little bit more realistic. If anybody watches Homeland on Showtime, apparently Claire Danes' character got ECT. I didn't see it, but I was told by my colleagues that it was a relatively realistic portrayal of the procedure itself. There are lots of books written. Kitty Dukakis is a famous person who's gotten ECT. She has a book called Shock, and a couple of other people too. So that's an option. Again, it's something to be considered along with other things, or if other things haven't helped, or even consultation with your team. You guys have cards. So, does lithium work for everyone? No. There's a thought out there that maybe it's 50-50. So, you know, if you don't respond to lithium or don't tolerate lithium, you're in the half that doesn't. That's not even to say that if you're in the half that does respond, that you have to be on lithium. I just use that as an example because, sort of like ECT, number one, in the face of, or in competition with things that are newer and more, I don't know, exciting, lithium has sort of been on a decline, or was for a while, but it's still far and away the best thing we have. And my mantra in the hospital when I'm seeing somebody who is either newly diagnosed or not, if they haven't had a trial of lithium, they deserve a trial of lithium. And I do mean that they deserve a trial of lithium, that the most helpful thing out there, they should have a shot at. If it doesn't work out, then we work with it, okay? But it does not work for everyone. I didn't want to give you that impression. We say this sometimes partially kidding, but it's true. It's the most natural treatment that we have. It comes out of the ground. It's on the periodic table, etc.
Sure. So this question asks, how do I find a therapist or psychiatrist that specializes in bipolar disorder? This is a really good question, and it's kind of hard for me to answer it directly. I can speak to the clinic I work in at University of Michigan. We do have a specialty clinic that works with bipolar disorder. Unfortunately, though, due to availability and just the number of people who are looking for that type of treatment and how many therapists we have, we are unable to treat every person who comes to our clinic and is looking for a therapist or a psychiatrist. But what we are really good at is we are able to give very in-depth consultations and evaluations to see what the needs are. And then what we do is we are able to connect people looking for treatment with psychiatrists or therapists in the community that will be able to give them that ongoing care. So that is one way of finding a psychiatrist or therapist. Other ways of finding a psychiatrist or therapist, if you do have insurance, would be to contact your insurance company and ask them for referrals for behavioral health specialists in your area. And then more than likely, if you're calling a clinic, when you go through the intake process and they ask you what your needs are and why you're calling to make the appointment, they'll be able to set you up with a psychiatrist or a therapist that is trained in treating bipolar disorder. On the other hand, if you do not have insurance, we do have flyers on the table outside of the door that has a list of providers in the Washtenaw County area that you can call and hopefully receive the treatment that you need. And they'll be able to also take you through an intake process and connect you with a therapist and a psychiatrist that will be able to treat what your needs are.
How can you tell the difference between a panic episode and a really depressed episode? Do they kind of go hand in hand?
Between a panic episode?
Yes.
So that's a good question because panic and anxiety often goes hand in hand with depression. And so you often see panic and anxiety in bipolar disorder. The way I like to think about panic attacks and anxiety is as an intense fear response. So usually when you have anxiety, you have some physical symptoms that that goes with it. So you might have a racing heartbeat, you might be sweating, you might have a choking feeling, you might feel nauseated, like you're going to throw up, trembling. Sometimes people have numbness and tingling in their fingers and toes.
Yes.
Yep. Fast breathing. So any and all of those things can go along with anxiety. That's the way I usually think about it. Think about how you would feel if you were being chased by a bear. And it's kind of like a version of that. That's anxiety or panic.
And keep people that are on meds for depression, bipolar, anxiety, will they stay on these meds if they're working the rest of their lives as a rule? Till natural death.
So that's a good question. Dr. Bess could probably answer this with me, but it just depends on the patient, and it depends on their symptoms and how often they happen. So for most people who have one depressive episode in their life, we would typically want to see them improve for a period of 6 months to a year, and then give them the option, I mean, it's always your option to go on or off medication. Once people have had 2 major depressive episodes, we start getting more serious about saying maybe you should be on medication for life, because of the risks with depression. Now, with mania, mania can have some pretty serious symptoms that go along with it, and the risk of suicide is high, and people have sometimes some unusual experiences that we call psychotic symptoms. And those can be very life-threatening. So in the same way that you would stay on blood pressure medication for life, or diabetes medication like insulin for life, we start to get more serious about that with bipolar disorder. So it's an individual decision, but we base it on how severe the symptoms are and how often they happen in your lifetime.
What if they're every single day?
I mean, I think the message is, just like heart disease or blood pressure or diabetes, these are very often things that they're going to be treated until you die from something else. And there are some specific algorithms like Dr. Mortenson mentioned, but someone who suffered for years or has had several episodes, the rule is that you're in some sort of treatment for the rest of your life. If medication is what works for you, my parents weren't educated, but my dad said if it ain't broke, don't fix it. So if the medications are working, stick with it. It's a really heavy thing. It's when people, especially young people, but really anybody, thinks about the fact that they have to take something every day forever, it just doesn't jive. We do this all the time, so it's easy for us to talk about, of course, but really that's what we encourage people to do.
Because I asked my psychiatrist if I went off of the meds, either voluntarily or they took me off it, I didn't take it, if I don't take it at all, what could happen?
Yeah.
And she said I go into a very manic depressive state.
Yeah.
I would be absolutely probably hospitalized.
Yeah.
Most likely.
Yeah. That's right. And it's not like it doesn't happen immediately necessarily, but it's something we see every day. Why? How did this happen? What happened to you in the last couple of months that's been different than before? This is in the hospital, mind you. I was feeling better, so I stopped my meds. Every single day. I'm not minimizing that. It's a big deal, and you're putting chemicals in your body, and I understand that that's not ideal. So it's a struggle. It's a struggle for everybody every single day to put that pill in their mouth. Even though they know it helps them, it doesn't necessarily feel right. I may have been being rude regardless of my intentions, but somebody was asking about Fight Club, and I hadn't seen it, so I was looking it up. Fight Club, are there groups for unusual conditions like the one in Fight Club? Was it realistic? You guys?
It's such a long time.
So it's dissociative identity disorder. So I can't say whether it was realistic. There were a whole bunch of other movies. Wikipedia apparently has a great article on mental illnesses in movies. There's a whole list of movies with dissociative identity disorder and other ones too. There are, I can't name them off the top of my head. Dissociative identity disorder is relatively rare. And so, let's say a support group for that versus bipolar disorder might be harder to find, but they're out there. It's possible to to find them. It might be an online resource would be helpful or something like that. What books can you recommend to learn more? So there's well, it's part of our operation, but there's a separate website, and is this written down somewhere out there?
There's the cards.
Little cards for depressiontoolkit.org. All one word, there are little cards out there. You know, it's geared toward, well, really, it's helpful for anybody. I go to it myself to look to see what resources are available for people who ask that very question. You know, are there books, or what books can we recommend? I mean, the list is endless. We all have our favorites, but there are resources listed there. I think, and I'll just put in one plug, and I'll give you guys the opportunity as well. I think anybody who either has bipolar disorder or has a close person in their life with bipolar disorder, you know, you really should read Unquiet Mind. Unquiet Mind, yeah. It's an autobiography of somebody's bipolar disorder. And, you know, I read it for the first time probably just 2 years ago. And it's moving, even if you're not a person who deals with this, you know, personally. But it has a very good message, and the person who wrote it, you know, is a professor at Hopkins and is one of the preeminent researchers on bipolar disorder. She's a psychologist and has done amazing things with her life and her work. But what came out of that book, and there are a couple of others that she's written since then, but what came out of that book was the suffering, the pain that this woman went through in her early years in college and graduate school. The closeness to suicide, the ambivalence and the bad feelings about having to take medication. So I recommend that one. You guys have a favorite that you always... I have a little printout in my office, actually, with a picture of it, and I hand it to people. So depressiontoolkit.org, check it out. Is there a way to pinpoint mania or depression in someone who's on medication? That makes it hard. You know, the medications are supposed to blunt the symptoms, and so, you know, there's this concept that we call partially treated, right? So if somebody's on a mood stabilizer, their mania or their episode may look different than someone who's not. You know, sometimes it's still the same symptoms, or they can take different forms, but you can pinpoint it. I mean, you know, if you're on an antidepressant, you can certainly still be depressed if it's not helping you. But it can be different. Some antidepressants are very sedating, and so you don't have the sleep problems that usually come with depression, but you have some of the others. You know, and that's where an expert, either physician or other professional, can help you sort those things out.
Yeah, I have a question. Can anyone go to Packard Health, explain their services? So yes, Packard Health is a primary care office. It's open to the community. We have a unique partnership with Washington Community Mental Health, where it has embedded myself as a mental health professional and a psychiatrist who's there 4 hours a week. They've embedded us into a primary care office. So essentially, you can go to one location and establish with a primary care doctor and get all of your physical health needs met. And then we're also there to not only back up the physicians who treat you, but intervene and have more specialized services if you need that in terms of your mental health. What's really great about having integrated care is, you know, as Dr. Bess talked about, the comorbidity of medical conditions because of the psychiatric medicines that we put people on. There is a higher prevalence for heart disease and for diabetes. Sometimes that doesn't always get monitored as much as it should in a traditional psychiatric clinic. So having it in a medical clinic where you've got your primary care doctor talking to your mental health professional, talking to the psychiatrist, all sharing the same record, all knowing exactly what is happening every time you walk through the door is really valuable, in my opinion.
Someone asked, could bipolar be set off by an accident or another, or a traumatic event of some kind. And I'm not sure if the question is asking about sort of a first-time event or later event.
What I'm saying, or what I'm asking is 4 years ago, at the same time, she got diagnosed with bipolar and depression. Was we were in a relatively severe car accident, both of us severely hurt, and they came into my wife's room and they said, well, congratulations, Mrs. Lamb, you're going to live, you got a broken wrist, a broken ankle. Oh, by the way, you're bipolar.
And
we had, in 30-some years of marriage, it had never raised its ugly head. But there it was.
And so there was a diagnosis made.
yes, I was diagnosed with bipolar because I was driving drunk, which I shouldn't have done, but I did it. And I've lived that the rest of my life, but I don't drink now. And we were in a very severe car accident. And because I felt so guilty and just blamed myself and everything, I was crying all the time, couldn't eat, couldn't sleep. And then went to the doctor. That's when he diagnosed me. That was probably bipolar, depressive, I don't know about mania. I'm not schizophrenic that I know of. I don't hear voices in my head. But that's what he's asking, is could this all have just regressed when we were in the accident?
Well, it's a really good question. Most episodes of depression do happen in the context of a major life stressor. So sometimes people will say, well, isn't this just a normal reaction to something really bad happening in my life, like losing a job or losing a loved one or something else traumatic happening? And there are normal grief reactions and normal reactions of loss. But then, thinking about reactions on a spectrum, there are reactions that are more severe. And stress affects the body in a really, really big way.
I'm stressed
And there
out.
are stress hormones that all get flooded into your body when you go through a stressful life event. So for sure, depression and mania, all of those things can emerge out of a stressful life event. In fact, one of the therapies that we use for bipolar disorder is called social rhythm therapy. And one of the focus of that is on keeping a regular schedule, regular sleep schedule, eating schedule, and trying to regularize your life so that you have less stress. So stress is a really, really big part of what we deal with every day in depression and bipolar disorder.
Very early in my talk, a lot of that was put together by one of our colleagues, Dr. McGinnis, and he's actually the one who taught me the 80% thing. But it said 80%, bipolar disorder is 80% genetic, remember?
Yeah. Well, her whole family's.
Right.
We're all bipolar.
But then the follow-up line was, and 100%, it's 100% environmental. And that's a little bit of a play on words, but that's exactly what Dr. Mortenson's talking about. The current understanding is that you inherit vulnerability, okay? A baby isn't born manic, right? But it inherits vulnerability toward the mental illness. And then when something terrible happens, or some life stressor happens, or a trauma, then it's triggered. So the simple answer to your question is yes. Does that make it an even more complicated? Yes. It can definitely happen.
So this question asked, please explain the Packard longitudinal study in clinical trials. So the Packard Bipolar Research Fund at the University of Michigan has a number of different research studies that are going on right now. One of them is the longitudinal study, which is an observational-only study that follows participants over 10 years. So when I say observational, what that means is that you're not actually receiving any type of treatment, so you're not getting therapy and you're not getting any type of medication management. But we do send out questionnaires and we do interviews with these participants every couple of months and over the span of 10 years. And the purpose of this study is to really see how bipolar disorder possibly changes for people over time. And there's a genetic piece to this. So why is it that some people respond better to certain things than other people? And why is it that some people end up unemployed and have to claim disability? And why is it that some people can continue on and work full time and have higher functioning? So it's a really great opportunity for us to see the trend and see how bipolar disorder affects people differently. Right now, I believe we have somewhere around 800 participants in this study. So it's hopefully going to render some really interesting results at the end of that 10 years. And in terms of the clinical trials, we do have a number of trials going on right now that do involve treatment. Right now, we have a study that is looking at the difference in effectiveness between lithium and Seroquel. And then we also have a study that's looking at lithium monotherapy. And, criteria, some people may or may not be able to get into these studies based off of different reasons. But if this sounds like something that you may be interested in, there is information on the table when you leave that you can get regarding how to become an active and a participant in these studies if that's something that interests you.
How unlikely is a person treated for depression for 30 years? How unlikely is it that that person would then be diagnosed bipolar at 60 years old after being retired? Actually, not unlikely. I mean, it happens with some frequency. Two things to think about. One is that the way the diagnostic system works, you can be depressed your entire life, and if you have one manic episode when you're 60, you're bipolar. You can have a manic episode when you're 18, never have a manic episode again, you can have depression maybe, then you're bipolar. So that manic episode is kind of like a flag in your chart or record or memory or whatever, that this is bipolar disorder. We see people, where Roth's mentioned retirement, we see people all the time at life stage changes. And like we were talking about earlier, these stresses or these events in our lives that then trigger an episode. I could probably even think of specific examples of people I've worked with recently who had exactly that. Either they had depression that was triggered by retirement and the changes that brought, or that they may have had depression over the years, had a manic episode or something else that happened much later in life. So it's pretty common. I mean, it's pretty common. It's not everybody, but people wouldn't look at you and think that you were very strange. It definitely happens.
I'm a twin, I'm a triplet, but I have a twin that has tried to commit suicide probably in 30 years, probably 30 times. And she's also an addict, she's antidepressive, and I ask her all the time, before you do something stupid, why don't you just talk to me? Tell me how you're feeling, what you feel. Is that the way to go about it, or I can't ignore it anymore. I just can't ignore it. Yeah?
Be available. Yeah, that is the way to go about it. Every situation is different, but just to, sometimes all we can do is let people know that we're available and that we're willing to listen.
Well, that's what I told her.
And I think, something you're describing speaks to one of the problems in bipolar disorder is often there's a very high amount of impulsivity, where, like that race car analogy, where the brakes are not as strong.
Well, she's on every medication.
Right. But that's what we get worried about with bipolar disorder and depression is impulsivity, and sometimes that people are just not able to rein in their impulses as much, and so sometimes even the best interventions can be very difficult because of that very strong urge to do something when people are suffering.
Yeah, she says that she has no control over it.
I'm out of cards. Other questions? Yeah.
And this is not a question. Since my wife has been diagnosed with bipolar, the first doctor was somewhat helpful. I've talked to 2 or 3 other doctors, and I asked them, what can I do? My wife's bipolar, what can I do to help? One doctor told me to learn to live with it. Another one, basically, he didn't come right out and say, sucks to be you, but that was his attitude. And the third one just went, I don't know. How come most general practitioners can't give you the answers you need to hear.
And what is bipolar, the definition? What is depression, the definition?
These
When we
gentlemen
say we
just
got
start bringing-
bipolar, or you're depressed, you know, and you're like, well, what is it? And what do we do about it? You know, do we do medication? Do we see psychiatrists? That's basically his question to all the doctors. What is it? What defines it?
And I want to thank you also for this, because I learned more than I have in the last 4 years.
Well, and I think, just to say something about what you're going through is that unfortunately, your experience is not unusual. And that's why these support groups are really helpful. Being able to surround yourself with people that have been dealing with it and have learned the skills and have learned the techniques for how to manage it. It sounds to me like this is something that has kind of become a part of your life more recently. But there are people like at NAMI support groups and at the support groups you can find at the University of Michigan who, this has been a part of their life for much longer. So I think that, being able to get some of that support would be really helpful. There's also a group at the University of Michigan that meets once a month that is actually more of an educational opportunity where it actually explains what bipolar disorder is, what depression is, how that affects people, different treatment recommendations, much like what we discussed today. That's really helpful because being educated and being informed is half the battle with learning how to manage it.
Right.
So I'm sorry to hear that's been your experience in the primary care setting. Unfortunately, a lot of clinics are not as lucky to have mental health practitioners like the Packard Clinic in that setting who are educated and informed on these types of diagnoses.
Well, I go to Packard Road, I'm a patient there. Amy's my counselor, yay! I meet with psychiatrists once a month, usually on a Wednesday, and I'm able to, pour out stuff that I wouldn't tell you or her or you because it hurts too much. It just hurts.
And being able to, surround yourself with other people who also know and have experienced that hurt firsthand can be really helpful in your own process. So I would definitely consider taking advantage of some of those support group opportunities.
The number one factor, and study after study shows that the number one factor in whether non-medical treatment is helpful is how much you trust the person and the relationship that you have. So it doesn't matter what school they went to, what books they read or wrote, or how famous they are. That's right. So, and frankly, some of that even factors into medical treatment too, like the psychiatrist. If your psychiatrist is a jerk, the meds aren't going to work as well. I mean, studies show that. So, so that's, I say that to also say, even if you're one of the, if you're a person who can't make it to one of the support groups, or if you don't have insurance that lets you go to U of M or St. Joe's, and you have to go here or there. I mean, if you keep searching until you find the right person, wherever they may be, that's going to be helpful to you. It could be a counselor at church. It could be, I'm not talking about a family member. That's you need somebody who's outside of things. But there are lots of different people available, and as long as you're the person, that's the person that you're willing to talk to, that's what's important. Any other questions? Yeah.
I wanted to know if bipolar disorder has connection to dementia or Alzheimer's.
It can, back in the old days, when things were diagnosed a little bit differently and we didn't have all these interventions to talk about, people who were in these hospitals for years and years and years would almost invariably end up with dementia. And that's more true of, say, schizophrenia, but there is some overlap. And so, will a person with bipolar disorder always end up with dementia? No. I don't even think it's a majority. But is there some correlation that maybe we don't understand yet? Yeah, it's something to be on the lookout for. What else? So, you guys have anything else you want to say? Well, we can end the formal, as formal as this is, part of the session. You know, I'm happy to stick around for a few minutes if anybody has any other questions and maybe they weren't comfortable bringing up in front of everyone. I won't speak for my colleagues, but one of the ones people I'm sure I spoke for them, but they will too. But feel free, we'll be here for a couple of minutes and then all the information out there that's at can help you navigate. So thank you for coming, appreciate it.